This can...
As I start blowing.
Yeah, I was gonna say, well, bad timing.
Sorry.
Sorry. So funny. All right. Well, so tonight we have Destiny Gelman here with us. She is going to talk to us about basically, I mean, something that we've all been talking a lot about over the last few weeks, how we can support our postpartum moms with their mental health. When are we referring to someone such as herself? All the things. I think it's a huge part of what we do in our line of work. And we're always, we might have the moms who do approach us. I know Hannah and I both in the last couple weeks had a mom approaching us asking for help. What do we do? So finding the right words for that is huge. So I'll let Destiny introduce herself and she can kind of tell us a little bit more.
Give me one second
And I'm
because
also going to
I
make you a
am
co-host.
okay, perfect. Because I have absolutely nothing is happening when I click on my meeting to share anything.
Yeah, now you're a co-host.
All right. I'm still getting no options.
Really?
Yeah.
Huh. You should. Maybe I'll just make you host. The only thing I don't know if I can do that actually if I'm recording. If I can, you'll just have to be the one who admits anybody if they try to come in. Is that helping?
No. I don't know what's going on. This
That is
is
so strange.
all right. Zoom is just not cooperating. I'm trying to see.
Okay, well, if you can make me host again, then I
Okay.
will see if let me let me go into my Gmail and I'll pull up where is it? You sent it to me today. Where did I tell you to send it to me? Let's see.
Your Gmail.
Yeah. Oh, it's just not your name. Okay, here we go. Here we go. Put it up. Okay, so I will. Do you want me to go ahead and share my screen then?
Yes, go ahead. I'm getting still no options, so there must be
That is
some weird glitch in Zoom on
so
my end.
strange.
So
Okay.
whatever works.
Oh, if I can, I'm sure I don't know if I can make it full screen, but we're just gonna,
Good enough.
yeah, close. There we go.
Got it. All right. I'll just tell you when to scroll down, but it's probably pretty
Okay,
self-explanatory at this
perfect.
point too. All right, you can just go to the next slide. This one's really just the
Please.
name of my business. So a little bit about me. This is my family. These are my babies who are not babies any longer. I'm a licensed marriage and family therapist. I have been practicing for over 15 years at this point. I'm perinatal mental health certified, when was one of the first people to be so when PSI started it a little ways back. Um, I am EMDR trained and actively working towards certification. EMDR is a phenomenal trauma resolution type of therapy that is one of the only scientifically backed types of therapy. So there's actual scientific proof to show that it's effective, which is really cool. And I am a wife, obviously a mom, a dog mom. Mine will probably pop her head up here at some point too. And a NICU mom twice over with a lot of pregnancy complications and birth and delivery trauma. So a lot of medical complications for both of my children ongoing. So a big part of what brought me to the perinatal space, right? So having gone through my own experience, I went and did therapy for myself and saw the tremendous benefit in that and decided that I wanted to pursue a focus more in perinatal mental health as opposed to just more generic therapy as well. So, yeah, next slide. I'm just going to go over. I gave a good amount of detail in the slides. I'll give you guys a synopsis of everything, but you're not going to be diagnosing or treating these moms or dads. So I just felt like it was important for you to have some idea of how common these things are, how they might present, and what to do with them. So I'll go over depression, anxiety, PTSD, OCD, bipolar, psychosis. Also go over stuff for dads, stuff for the relationship, and that kind of stuff. So go ahead and scroll down. All right. Perinatal depression. Obviously, this is one that can pop up at any point throughout pregnancy or up to 1 year after they deliver the baby. It's estimated that about 20% of birthing individuals have this. I'm just going to put a side note. I do think a lot of these things are underreported. I think a lot of people don't seek the help that they need. And so I think this number is actually much larger and much larger since COVID than ever before, too. So keep that in mind as I'm giving prevalence. That's just my personal and clinical opinion that I think is higher than what it says. Um, there is a difference between baby blues versus depression. I know when I popped on, I heard you guys just talking about some baby blues type of stuff. And I don't know how much you guys know about that. Baby blues typically is, something that pops up within 2 days of delivering, lasts about 2 weeks. There's a lot of weepiness, a lot of exhaustion, right? A kind of teary mood. But the predominant mood for a mom who just has the baby blues is still happiness or joy, right? And they're in that massive hormonal flux. So they're going to have a lot of these emotions rapidly changing. But the biggest one is going to be happiness or joy. Depression can also manifest pretty early in. Typically, it takes up to about 2 weeks, but that's not true for everybody. So, the difference with that is depression, the predominant feeling is typically not going to be happiness or joy. So, it's going to be more low mood and symptoms that I'm going to go over on the next page for you. About half of, sorry, here she is. About half of the people who do experience perinatal depression are undiagnosed or untreated. Yes. And if they are still untreated at 1 year mark, typically these symptoms are going to persist for much longer. They're going to become more of a chronic thing for them. And this is true for all perinatal diagnoses, not just for depression. So it's so important to get in there during that early window where they're starting to first exhibit the symptoms. Okay. Obviously, the biggest things that we know are helpful, psychopharmacology, depending upon the severity of things for mom, and therapy. So, yeah, you can go ahead and scroll down to the next one. Sorry, she's going to be a little more in our face now that I'm talking. So these are some of those symptoms that you would notice in a mom who is having some depressive episode. So a constant or persistent low mood, feeling more sad or more tearful majority of the time. Physical complaints, so typically things like feeling really achy, really run down, a little flu-like for a lot of people. Difficulty concentrating, a lot of irritability or rage, hopelessness, guilt, shame, anhedonia, which is a total lack of interest in doing anything that they used to love to do. So they used to love to go out with their friends or knit or I don't know, do anything. And suddenly those things no longer seem appealing. I just don't have the desire to do it. And then one of the other things is lack of feeling towards the baby. So they might be struggling to bond with the baby. They might not feel connected. They might not feel any sense of love with the baby. Common thoughts that we might see a mom having with depressive perinatal depression are things like, I feel crazy. I'm a really bad mom. I'm doing something wrong. This baby would be better off without me, with anybody else. All of these things. Postpartum rage is also very highly correlated with anxiety and depression. So if a mom is reporting really intense episodes of irritability and rage, it's a pretty big flag for they have some type of perinatal depression or anxiety going on. So, all right, perinatal anxiety. So similar onset for all of these is pretty much going to be during pregnancy or within 1 year of delivery. Estimated that about 20% of new moms experience this. This number is significantly higher for moms who've had any type of trauma at any span throughout this perinatal window. Symptoms can be panicky or can be more like generalized anxiety. They do manifest a little bit differently. And there's a lot of comorbidity here with depression. So people who might have one now might have both. So I'm really anxious and I'm really hopeless and worthless. And these two things are just working together against me. Um, some important things to think about with anxiety. Sometimes hormones can be really helpful with anxiety in terms of mom might not feel the intensity that she might have previously had if she had a history. So it might make her think she's getting better. And then there's typically a resurgence at some point throughout pregnancy or at some point in the postpartum window where those hormones settle a little bit or shift, and suddenly this anxiety feels really intense over time. Um, down to symptoms. So I broke it into two different sections for you. You've got more of the generalized anxiety symptoms. Irritability, again, is here as one of those main symptoms, consistent with rage. This is constant worrying, worrying over baby, worrying over health for them, for their baby, worrying over safety, worrying over the family unit and how to ensure that their family unit stays safe and secure. A lot of worrying just all of the time. Hypervigilance. So they are super aware of all of the things going on around them, constantly wanting to check to make sure baby is doing the things that they're supposed to be doing. Mom is probably having some appetite changes, either eating more, eating less, not sleeping well. With anxiety, we usually see that moms will have a harder time falling asleep at the start of the night, and they might wake through the night, but it's typically more in that early window. Exhaustion might benefit them in falling asleep a little easier, but anxiety peaks more in the evening hours.
Sorry,
Uh,
I'm trying to find people in the waiting room, and sorry,
you're good.
I
You're
don't.
good.
Oh,
My
now I see. Now I see. Okay,
whatever you just did, I suddenly got back all of my controls. If you want me to take over the
oh,
road there,
go for it, because then
you want
maybe
me to do
I'll
it?
actually be able to see.
Yeah.
Yeah,
All right.
sorry about that.
It's okay. Let me just find where I was so that I can share. We should be good. Working beautifully. It's still not.
Oh, it
It's
went away
freezing
now.
when I try.
Okay.
I'm sorry. I
Oh,
don't
what I
understand
did
what
that
is
made it
going
just
on.
okay. Hang on then. Let me just reshare.
Ah, nope. It
Oh, you
just
got
gave
it?
me the option, I
Okay,
think. Let's try it.
go for it.
It's not. It's forcing me to do something different.
So weird. Okay,
Yeah.
I can share again. I just might have to pause if anybody else wants to come back in.
If you need me to pause, just tell me at any point.
Okay. Can you see it again?
Yep, we're good. Other things that mom might experience are those racing thoughts. So some of those worries, they just are super persistent and they will keep coming back. And a lot of moms just feel like it is so noisy in their head. They might have some heart palpitations, some shortness of breath. Rumination is that same idea, those things going over and over and over in their mind. And they might also become more restless, more fidgety, more likely to not settle down and just relax when the baby is sleeping and wanting to get all the things done. When we look at episodes of panic, these are smaller chunks of time where there is extreme anxiety. So it can be just a few moments, or it can last up to an hour. In very severe cases, longer than that, but that's not typical. Usually, there's a lot of somatic things that happen here. So, shortness of breath, chest pain, really rapid heart rate. They are dizzy, they're lightheaded, they might be shaking, numbing, or tingling. Hot or cold flashes. It is very intense. Most people feel like they are having a heart attack. And it takes a lot of effort to come back down and calm themselves and then to re regulate to enter back into whatever they were going to try to do before that panic attack happened. A lot of irritability happens with this, mostly because of the amount of energy that's required to have a panic attack and to come back from that panic attack. So it leaves you feeling really depleted. And they can happen at any time of day or night. The most common fears that might that might trigger one of these panic attacks are things like dying. Mom, baby, doesn't really matter. Anything health related or safety related, again. A lot of worries about, am I going crazy? What's going on? What's going wrong with me? A lot of fears about losing control and having no control during this really vulnerable time. And again, safety. Safety is pretty much one of those biggest triggers for you. Perinatal OCD. So again, same idea during pregnancy or within 1 year post-delivery for the onset. Prevalence 5 to 15% of women in the perinatal time period. When perinatal women are at a 1.5 to 2 times greater risk than the general public in not contracting, but in getting OCD. And that's a really big jump. They typically are going to have difficulty in functioning if they cannot engage in the compulsions. The anxiety will feel too tremendous that they can't necessarily continue with whatever they might need to be doing in that moment. Um, Most will have really intrusive, repetitive thoughts that are typically indicative of some kind of harm to themselves or harm to the baby. And these can be accompanied by really grave visualizations. One good example I can give that most of us have experienced at some point in our life is if you're sitting at a stoplight and you are the driver of the car and you envision another car just flying through that stoplight and smashing into your car, right? And you can see it, you can picture it, you can feel all the feelings, and you start to immediately have panic. Even if in your rational mind, you know that that's not what's about to happen. And that's an intrusive thought, right? Except when you're in the perinatal stage and when it's OCD, it doesn't just go away when you go, that's not rational. It is persistent and it is nagging and it will keep coming back for those moms. And it might manifest in different ways. Um, these thoughts cause a tremendous amount of distress, a lot of guilt and shame because of what is coming up, because typically they are visualizations of things that are not really comforting. Like, what happens if I'm giving my baby a bath and they fall below the water and I don't pick them up, right? Or what happens if I'm walking past the staircase and I drop my baby? These aren't things mom wants to happen, and they create a lot of these conflicting emotions because of just the gravity of them. The biggest difference with perinatal OCD and psychosis, which is what a lot of moms who have OCD worry that they have because of these visualizations, right, is this distress. If these thoughts cause you distress, that is a really good thing. That means you recognize that that's not a normal, healthy thought, and that that's not something you want to do, right? A mom who is in psychosis is going to find comfort in these thoughts. It is very different. So it's important to remind any mom who's having these intrusive thoughts that the thoughts do not actually equal any type of action. Okay. These moms are also, again, very concerned with being crazy and being seen as crazy. Thoughts are obsessive and frightening to her. So um, here I put a really great diagram that I think is helpful, especially if you don't work with this on a regular basis, to get a little bit of understanding about what OCD looks like. And it's super confusing, so I'm going to walk you through it. The top part are those intrusive thoughts. So this little 6 or 7 icons are the things that make up what an intrusive thought it could be, right? So it might be a memory. It might be a traumatic memory from childhood that just automatically comes back up into mind and triggers something. It might be an urge or an impulse, like a fear of not being able to control myself and doing something really bad, like that bathtub scenario that I just mentioned. It might be worry of losing it or snapping, right? Going off the deep end. It's visualizations or images, like I mentioned at the stoplight. It's ideas of things that could happen. And it's sensations. It's a lot of those physical symptoms of anxiety that might start to manifest. So all of those are intrusive thoughts. And then what happens is when they come, we begin to assign meaning to that. This means I'm crazy. This means I'm going to hurt my baby. This means I'm going to do whatever it is, right? I feel really anxious. That's the distress that's caused. So I engage in a compulsion. A compulsion can look like an overt behavior. That might be things like cleaning, checking, ordering, counting, or saying things out loud. This is where a lot of moms in this phase are constantly checking the baby, obsessing over the monitor, tracking intake for the baby or output for the baby, right? Things that are going above and beyond what a mom who's not got OCD would have. Can also be mental rituals. So those are really obsessions or concerns about the state of the home, about harming yourself or harming your baby. It can be counting inside of your head. It can be religious in nature, and you can pray a lot or repeat the same things over and over and over to yourself. Hypervigilance, so being incredibly aware of everything going on around me, and especially again, anything care related to the baby. I am going to be so hyper attuned to this baby. Um, and then you've got reassurance seeking. This is where they're probably saying to you, am I crazy? Am I going to be one of those moms who goes and does this thing? Right? They're starting to worry about that, and they want to seek that reassurance from people that they can trust. Their partners are also a major source of reassurance here. Or they avoid things altogether, and that's the only way to feel better about it. So I'm going to completely avoid the baby so that I don't hurt the baby. When they engage in the compulsion, they find relief, and it keeps the cycle going over and over and over. So, um, perinatal bipolar. This is not one that I see a lot in my practice, and it just typically I would refer out because it's not my specialty. But a lot of people, if they have previously been diagnosed, right, you have a 70% chance of a reoccurrence during the perinatal time period. That is massive. And a lot of that is because a lot of women do end up stopping medications when they get pregnant. So we know that if mood stabilizers are stopped, they are 2 times higher likelihood to have a reoccurrence some point during pregnancy or perinatal time period. Most of these women typically manifest as depressed. If you are seeing somebody who you know has history of bipolar or psychosis, it's really important to get them seen with a perinatal psychiatrist right away. So different things that you might see, you can scroll down. These are the different symptoms that you might see if they are in the depressive state, right? So these are very similar things to what I listed earlier. You've got a lot of like feeling weepy, feeling hopeless, low energy, suicidal thoughts and self-harm, persistent negative beliefs. You'd see some of these perhaps, or you might see what's on the next page and see more of, oh, I'm sorry, I don't know where that's went. Or you might see more of the, like there's manic or hypomanic type of symptoms, which are just really elevated mood, where they have a lot of energy, they're not sleeping, right? They're doing so much that just doesn't make sense for their phase of life. Hypomanic is typically much less intense. They might still be sleeping, but there's something a little off. They seem really upbeat, unnaturally so. Manic is very obvious if somebody is having like rapid speech and just again not sleeping, not taking care of themselves, just going to the opposite extreme of depression. All right, perinatal and postpartum psychosis is the big one that most people are absolutely terrified of. So out of every 1,000 people, only 1 to 2 will develop psychosis. In all of my years as working as a perinatal therapist, I've only seen 1 have it. That doesn't mean it's not likely to happen tomorrow, unfortunately, right? We know that there are people who are just at higher risk. If you have a family history of bipolar or a family history of psychosis or personal history, you are more likely to experience this. First-time moms are also much more likely to experience postpartum psychosis, as well as stopping medications, complications during pregnancy, infant mortality and stillbirth. All of these things enhance your risk factor. And sleep deprivation is the biggest factor there. We see that a lot. That sleep deprivation, I am just not myself. My brain is not thinking correctly, and it just is an easy slide from there. If If you're seeing anybody with bipolar during pregnancy, it's really advised to make sure they're working with a reproductive psychiatrist and to continue on their medication. The reproductive psychiatrist is the best person who knows everything that's perfectly safe for that baby and for her, and is going to make sure she's well taken care of. Immediate postpartum treatment is essential, and good sleep is really essential. All of the symptoms that you would see with psychosis, um, most of them that people would notice would be like those delusions, those hallucinations, things that are going to seem very off-putting. Hallucinations can be visual, they can be tactile, I feel something on my skin, right? They can be olfactory, I can smell them, I can hear them. They can manifest in a lot of different ways. Delusions might be things like I'm being watched, or my baby is possessed by a demon, things like that. And again, the biggest difference between a mom who's experiencing perinatal psychosis versus a mom who has something like perinatal OCD is going to be the comfort that they feel when they think about that intrusive thought. Right? If my baby is possessed by a demon, then I must do something to get rid of this demon. It's going to help my baby. I'm doing the right thing. I'm a good mom by doing this. Right? And there's comfort there for them. So they don't have that same anxiety that a mom with OCD would experience. This right here is the biggest part of what I do. So my focus in work is perinatal PTSD across the spectrum. This is my jam. It is the place I enjoy working, because I think that there's so much relief that can come from moms when we focus and work through the traumas so that they can have a wonderful relationship with their baby growing into a child, or so that they can experience another pregnancy and not carry all that in, or so that they can look back to that pregnancy and experience it differently than it might have happened in the moment. And there's a lot of healing that can happen there. Trauma's in the eye of the beholder, and I think that's a really important thing for all of us to remember, right? Trauma is not just the soldier who fought in the war. It is a million different things that translate into losses or some type of emotional upset or lack of safety, a lack of control that contribute to how we feel and how we experienced that moment. So sometimes we call things like little t traumas or big T traumas, right? A little t trauma might be the comment the nurse made at the bedside when the patient delivered the baby. That was not really supportive. A big T trauma, that's hemorrhaging after you gave birth, right? Either one is still incredibly impactful for that mom. And they can set mom up to have trauma and symptoms of PTSD following this experience. Things that might counteract these traumas are things like a really wonderful support system, you guys being in the room with them and advocating for them, right? That can be a really wonderful way to offset some of those smaller traumas, not necessarily the big traumas. And I put a note in there at the bottom, birthing partners are really untreated and uncared for related to trauma. Hospitals don't focus on the impact of how we got the baby here and what that experience looked like for mom. So there's a little bit of a lack of treatment and a lack of care there. But my goodness, is dad ignored or partner ignored? Like that, this wasn't their thing. But they experienced that trauma too from a very different angle. Um, this is me and one of my little babies. A lot of symptoms that they experience when they are having PTSD, you get flashbacks or flooding. Flooding is just like that fight or flight kind of feeling where everything just flows right in and floods you and you just can't function. It's recurring dreams or nightmares that are usually incredibly disturbing or distressing. Avoidance of whatever that trigger might be. I don't want to go back to that OB because they made me feel so awful and because of what they did to me after I delivered, right? Or I don't want to go near the baby because I'm afraid that something's going to go wrong. It usually leads to a lot of isolation. My experience was different than every other mom around me. They had this perfect Pampers commercial and I didn't. How can I relate to them? They blame themselves, they blame others, they become hyper vigilant for safety purposes, right? Again, lack of interest in things that they used to love. Um, and they feel a constant reactivation or triggering from things in everyday life. One thing that, when I went through this was what stood out to me as like, oh, this is not normal, was my microwave dinged one day and it set me into fight or flight. And I'm in my home, my baby is over there, like perfectly content in his swing. And oh my goodness, look where I feel like I'm at. Right. And that can happen for moms with everything, everywhere they go, if they don't have that trauma healed. And dissociation or masking. You might see a mom who is traumatized, let's say in the NICU, right? I got this. I might be looking like a doctor and talking really well and just kind of showing face because it's the only way I feel safe. It is the only way to make sure I'm okay. Sources of trauma, and this is really just specific for this time period. Obviously, this list would be 12 pages long, if not more, if it included everything else, right? But you're talking about gynecological trauma or provider trauma, previous sexual trauma, infertility, emergency C-sections, complications during pregnancy, labor, delivery, or during the immediate postpartum window, diagnosis for mother or baby during pregnancy or following, premature birth, hemorrhaging, things that were done during labor delivery that mom didn't want, hyperemesis, NICU, post birth hospitalization for mom, COVID, breastfeeding, any kind of loss. Partners experience with PTSD. So they're probably going to have really similar symptoms because it's PTSD and it really doesn't change whether you're in the perinatal window or not. They're going to be more irritable. And I'm speaking a little bit more to men with this. Men are more prone to going to the irritability, more aggressive, rageful type of response, or avoidance, right? They're going to avoid taking care of the baby because they are afraid to do any harm to that baby. They're afraid to mess it up. I don't know what I'm doing. I'm not the mom. I can't figure this out. And they're usually going to hyper focus on things that they can control because men are typically problem solvers and that soothes anxiety. So I'm going to dive into work. I'm going to dive into things around the home that I know need to be taken care of. That feels safer for me. So for some people, this feels like they're checking out, right? If you're talking with mom, my partner's checking out. He's not here for me. He's not here for the baby. I feel abandoned or alone. And you might hear some of that language if dad is experiencing PTSD too. Same thing with mom. It will resurface if it's not resolved or treated. And therapy is beneficial at any point in this time if any of them experience trauma. So dad or partners experience perinatally. 1 in 10 dads experience perinatal and depression or anxiety. And this is also, I think, grossly unreported or underreported. Men typically don't seek out support when they're feeling this. Their support is usually their partner. And so they're not going to go to a doctor. They're not likely to reach out for that help. Mom having a PMAD or PTSD increases the chances that dad will also experience one. Dads are great at masking, right? Some of these parts of also checking out, like I mentioned before. They might start to have shifts in their relationship. They don't know what it's supposed to look like after they have the baby, and they're struggling with these expectations. They're unable to do the things that they might have done prior to having the baby. So they're going to struggle a little bit more with how do I cope if I can't go out with my buddies or if I can't take a 6-hour bike ride, whatever that might look like. If dad has a history of anxiety or depression, he's more likely to experience it again. Other things that might put dad at a higher risk are some of those changes to the relational dynamic, those natural shifts that have to happen when you have a baby, and how mom might be a little more focused on the baby and less focused on dad. And there's some disconnection that happens. This is very normative for this part of their life cycle. Dad might feel more worried about finances. Again, going back to the things that I can control, right? This might feel like one of those I can control or a piece of responsibility. He might feel burdened or trapped. Changes in life expectations and experiences. Again, like I can't do the things that I used to do, and I'm really struggling with that shift in that mindset. And then The same things mom might be experiencing: sleep deprivation, feeling helpless. I don't know how to help. Mom is breastfeeding. What do I do? Right? Feeling isolated, feeling alone. The biggest thing that I found that helps dads is normalization. So recognizing that they aren't the only dad who's ever struggled, right? This is a very normal thing to experience at this phase of life. Connecting with other dads. PSI has a lot of really great dads groups that they can meet even virtually or in person and just feel really supported, feel really seen here. Um, Another thing that's helpful, relieving them of tasks that allow them to mask or separate, right? So if they were doing yard work and spending 12 hours a week outside, well, maybe now we outsource that, right? So that dad can become a little bit more present and be here for the family and not mask or push away. Helping to find connection with his wife. So pulling in, talking with her, supporting him and helping him find ways to do that, or supporting her and helping to create that connection too. Not everything should be about the baby here. Um, Fostering communication with wife and with also other natural supports. So parents, friends, anybody else that might be around. Talking about expectations before mom delivers. It's really helpful for either parent to know these are the things that I think I might benefit from once this baby is here, right? These are the things that mom can take over. These are the things that dad can take over. And having those expectations or roles set in mind can reduce the implications of this afterwards. Obviously, therapy and education, I put them too because I think that's helpful for. So I put a few slides on how I think you guys can help. I think a lot of these things you're probably already doing just by being in the room, right? By being present with them, by being your normal, genuine selves. You're creating safe spaces, and there's a lot of value in that. But I think providing education or informing, mom and dad during pregnancy about some of these things that are going to happen. So what to expect during those first few months, not just the logistical parts, but those emotional parts, those relational parts. That's really helpful. The changes that are going to happen for them, the value in meeting basic needs, possibility and the symptoms of any perinatal mental health disorder, and the need to accept help. That's when a lot of people struggle with. I don't want my mom to come in and help here, right? I want to be able to do this on my own, or I don't feel comfortable asking for that person to step in. Again, helping to empower them and realize what they are capable of and what they can do and what they've overcome. Helping dad to find his place to care for the baby. And I should side note, helping mom to relinquish some control a little bit to let dad step in and find his place with the baby. That's usually an important part of that. If dad knows that he can get the baby to sleep just as well as mom, he's more likely to step in and offer support there. Again, relief from tasks, providing some of that practical assistance and the permission to say no. So if something doesn't work for them, letting them know that they can say no. You don't have to go to that family dinner. You don't have to take the baby to Christmas. You don't have to do something that you're not ready. You don't have to let people come over. I don't know how much you guys do this. I imagine a good amount, especially if you're with them during the birth and delivery process. But helping with coping strategies and mindfulness, breathing exercises, things like that, that can help them just re-regulate during the moment of intensity. Helping them both find ways to bond with the new baby. Helping mom or dad to advocate for themselves or their baby with the providers. Identifying flags and normalizing this to reduce stigma and the blame of seeking support. Connecting to community resources, providing warm leads. So that would be like not just a, hey, I looked up this list on your insurance website and here's a bunch of people that you can try to reach out to. The likelihood that mom or dad is ever going to follow through with any of those is pretty slim to none. If they know that you know this person, they are more likely to engage with them because they trust you and they know that you probably trust this person. You're not going to recommend somebody who you think sucks. And advocate for them to include natural supports. Again, those are extended family members, friends, can be a religious community, anything else as is tolerated. when you should refer for services. If there's a history of any type of unresolved trauma that they make you aware of. So this could be anything as far back from childhood. It's probably most relevant in your line of work, obviously, that has to do with any type of sexual abuse or gynecological trauma, anything like that, where you think this could surface, or anything truthfully surrounding safety or a theme of safety, because those things are likely to emerge again during the birthing process. At any point, if they start to exhibit signs of any of the disorders that we talked about, um, trust your judgment here, right? If something feels off for you, something probably is off. So just recognizing that your intuition is right. And if you think something is going on with mom or dad, it might be a time to have that discussion, even if you don't have the clinical symptoms to base it off of. Anytime there's perinatal loss, infertility, or perinatal trauma, especially if mom is pregnant again. If mom is pregnant again and those things have not been sorted through and healed, you're going to see a really big resurfacing at some point through the pregnancy or postpartum window of all of that trauma coming back. And especially too, if there's a NICU baby or a baby born with any type of medical complications, because those things require mom and dad to have ongoing emotional support. If there's a lack of supports, it's also a good thing to refer for services. Concerns about bonding with baby, or other major life stressors or significant changes. Dad lost his job a week before the baby was born, or we moved into a new house right as we had the baby, right? Good thing right there, but typically there's a lot of stress, and that just creates a massive upset in this developmental milestone. Uh, these are times where you should refer for dad, very similar types of things as to what you would see with mom. So I think there's really not a difference between when you would refer mom versus dad. It's just the recognition that their symptoms might manifest a little bit differently, and you might not also see his as clearly. So knowing that. Couples, I don't know how much you guys get to see the dynamic amongst mom and dad in those moments. But if you're noticing discomfort or tension between the partners, usually a good time to refer for services. If they're having parenting differences, or if you're noticing maybe even some cultural differences here, right? Dad thinks that mom should be the one who does all of the care for the baby at night because she's the woman. Well, we probably need to attune to that. That's likely going to lead for something for both of them. Any type of perinatal trauma, again, NICU baby or baby with medical complications, loss and infertility. A lot of these 3 or 4 things is because couples grieve and manage things in very different ways. How mom is handling it is going to be so vastly different from dad is handling it. And if they continue on this trajectory, they're likely not going to come back and find a connection to reinstate a healthier attachment. So we want to make sure that they can come back and find a healthier attachment so that they can parent that baby the best that they can. I also put in there when nothing is wrong. Sometimes we just need support through major developmental milestones. And this is one of the biggest ones that any of us ever go through. So having that support, having that person who could just boost you is really, really helpful. So benefits of therapy: to feel more empowered and more capable, to process through trauma, to reduce the presence of triggers right now as they happen, to identify ways to take care of yourself during times of intensity without it feeling like an extra burden or an extra task, to identify root causes of things and reduce the intensity, to create healthy attachment and bonding with children and with their partner, reduce blame and shame, to cope, to be more present in their relationships, in all relationships, to feel more like the person they want to be, and to have healthy boundaries. I'm not going to read this out loud because I think you're all capable, but Monica was like, oh, if you could put in some verbiage on how to present this for therapy, like how to present it to somebody. So I did a little bit of a blurb there. Again, you guys work with these women and these men for a lot of time during very vulnerable periods of time. And I think you probably, again, could trust your judgment with how you bring it up and how warm it is. But knowing that, mentioning it's a developmental milestone, mentioning that there's nothing to be ashamed of, that there's nothing that they did wrong, right? That these are normal feelings, and it's just helpful to seek extra support like they did by reaching out to you to be there for them during these windows of time, right? So, And a little bit about our practice. So I am the owner and the supervisor of the practice, but there are also three other perinatally trained therapists on my staff that specialize in working with moms and dads. We specialize in infertility, TFMR, loss, any type of loss, perinatal trauma, mood disorders, anxiety disorders, all of it. We utilize a lot of CBT, which is cognitive behavioral therapy, or dialectical behavioral therapy. Those are approaches that just help to challenge some of those intrusive thoughts. We do a lot of couples work, just talk therapy. Sometimes moms just need those spaces. I'm the only one who does EMDR, the others do not, but they do incorporate a lot of mindfulness and a lot of various trauma informed modalities to help the clients make progress and to move past whatever they experienced. So yeah, that's us. Probably worth noting, all of our therapy is held online because I started it when I was on bed rest for myself during my last pregnancy. And I was like, oh, wow, this works a lot better for all moms, and just never went back. And that was before the pandemic ever hit. So we've been doing this for a long time. Referrals that might need a higher level of care, I put back there because I think that's appropriate for you guys to also know, right? If they're presenting with a lot of suicidal ideation, homicidal ideation, if they're presenting with some of those red flags for psychosis or anything, we are just an outpatient place. We are probably not the right spot for them. And if they were to call or you were to call and let me know, I would send you somewhere else and tell you that it's not appropriate. We want them to be in a place where they're getting all of the care that they need and having someone more on call. If there's a history of bipolar too, especially if they're not receiving treatment, I would probably say this is not the accurate referral, or an ongoing addiction. So those are, we don't work with addiction. It's obviously we see people who have had addiction, but it's not something we actively service. And typically we just do one session, maybe two during some of those more intensive times a week. So if you think that they might need more than that, we are probably not the accurate place. And couples therapy can't ever be done if there's DV or suspected DV, domestic violence. That is all. Any questions?
Yeah. We've lost one. Um, I feel like you covered everything so well, so thoroughly. That was amazing.
Yeah.
Thank you. Do any of you guys have questions? This is like the smallest group I think we've ever. I don't know what happened tonight, but they're all gonna watch the recording.
They
I
can
have
always
a
send
I have a
messages.
question. Um, Hey Destiny, thank you for that. That was awesome. I just have a quick, well, I have lots of questions, but I'll do like one quick one.
Whatever
Um,
you have.
so I'm currently in grad school for clinical mental health counseling, and I
Awesome.
hope to work with it within the perinatal period as one of my like specialty areas.
Very
Um,
needed.
yeah, yeah, and so you mentioned your training that you did, but so a project, like a large capstone project that I'm going to be working on, is in regard to like the accessibility of training for perinatal therapists. And like, I'm curious if you have any insights around that of like, how often do you feel like you run into clinicians that don't feel um, like prepared or confident in working with this population? And if they know where they can get trained and what they would need to get those credentials and things like that. It's one
Good
of my
question.
questions.
Yeah, good question. I don't know how much other people realize that like PSI is a really wonderful support, right? And that they have so much ongoing training for providers. And I'm a big proponent of, if this is not your level of expertise, you really shouldn't be practicing in the space because this
Yeah.
is such a unique and vulnerable population. There
Mhm.
are a lot of great resources out there to get training, and
Yeah.
some are much more expensive and some are much more accessible or virtual versus in person.
Mhm.
It's there. I just don't know how much somebody who's not really looking to become more
Yeah.
versed in this might be looking
Yeah.
for it. But it's there for sure. And you can get it for anything. I mean, there's so many different types of training on this topic.
Mhm.
So
Yeah,
many.
true. And so you would recommend PSI as like the go-to, at least like starting point to access trainings and things like that?
I would. And the biggest reason that I would is because if you were interested in becoming certified to be a perinatal mental health counselor,
Hmm.
you'd have to go through PSI to a
Yeah.
degree anyway. So
Yeah.
any training you took would have to be approved by PSI. So why
Hmm.
not just go straight to the source? A lot of like ongoing trainings and stuff, you can go anywhere, right? A lot of my ongoing trainings are not actually through PSI, but because I do EMDR,
Hmm.
I'll do more ongoing perinatal focused EMDR
Yeah.
trainings,
Yeah.
right? So I'm getting a little
Hmm.
bit of both, but I would at least start with PSI.
Yeah. Okay. Cool. And then, okay, I'm gonna just sneak in one other quick
Yeah,
one while
of
I have the
course.
floor. So one of my things that I'm like kind of obsessed with is working. So I've been doing a lot of different projects on working with pregnant survivors of interpersonal trauma and like
Mhm.
trying to like utilize pregnancy as a healing opportunity. And I'm curious if you have any like resources or insights into that. I have compiled like many, but I'm always open ears for more of yeah, basically. And also I'm curious to hear if you kind of do that in your practice at all, like
Yeah.
addressing previous trauma through pregnancy, like as a
So the biggest way that I might do that is by highlighting attachment, right? And
mhm,
how we can attach with this baby that we don't really know and don't really have trust built in. And there's a lot of things that I do with moms throughout the entire pregnancy to help establish that connection with their baby and grow it moving forward. Um, in terms of utilizing the pregnancy to help, let's say, an injury with mom, right? I might do more of the opposite, where I might recognize how that injury with mom could come in and impact this pregnancy and this future relationship with baby,
mhm,
and how to promote healing on that end to find a healthier attachment and to stop this, cycle that the family has been in
mhm.
for future generations. So
Yeah.
I'm not sure if that answers what you're looking for.
No, yeah, that's great.
Yeah.
Yeah. And
Um,
do you have any like go-to books or inspiration, articles, things that, yeah.
yeah. Internal family systems, I think, is a
Yeah,
really wonderful thing that we can
I
use.
love IFS.
Um, is it can help transform us and heal some of those child parts or just any of
Yeah.
those parts that don't feel safe or protected, right?
Mhm,
And a lot of that just naturally weaves itself in naturally during
mhm.
this time period, right? Like there's different
Yeah.
parts of me that are coming up as I'm getting ready to become a mom, and this part is
Mhm.
scared and this part is excited.
Yeah.
Um, so that's a really great way to do that. Um, I can look and send resources if you want for things that I think might be helpful. A lot of it, at this point in my career, I probably fall more on just clinical judgment and expertise.
Yeah.
I use a lot of narrative and
I
experiential
love narrative therapy.
exercises to
Nice.
help just push mom into different stages and to help her like process through any types of traumas or again injuries that have happened. And a lot of talk about boundaries, right?
Mhm.
And how these things might have happened and we don't have to allow them to continue to happen. And here's how I can have control. And if I have control, I feel safer and
Mhm.
stuff. So,
Cool. Awesome.
yeah,
Thank you so much.
great questions.
Thanks.
Thank you very much. Is that everybody that has question? I'm gonna